Well, I'm going to move us on to palliative sedation then. And what I'm going to do is provide an overview in the following format. I'm going to give you a definition of palliative sedation that's in the literature and also one that I use in clinical practice. I'm going to use the results of a chart audit that we did in Calgary to demonstrate some of the challenges in using palliative sedation appropriately. And then I'm going to make some comments and perhaps ask your opinion about the use of palliative sedation for delirium. The definition that we use is one that was published quite some time ago by Dr. Chater from Ottawa and her colleagues. And it goes as follows. Palliative sedation is the intention of deliberately inducing and maintaining a deep sleep. So the patient is made unconscious for the purposes of relieving one or more intractable symptoms when all other possible interventions have failed and the patient is perceived to be close to death. An intractable symptom is pain, shortness of breath, nausea, delirium, any other symptom that cannot be managed acceptably in any other way other than to make the person unconscious. So it's calling us to think and work as hard as we can to develop ways to relieve that symptom, and we've come to the end of our list, and there's nothing else we can do. That is an intractable symptom. Some have referred to this palliative sedation as terminal sedation or sedation for intractable distress in the dying. What palliative sedation is not, and it's sometimes confused as, the use of medication to control delirium, the symptoms of delirium, or the use of medications to control anxiety or other distress such as hallucinations, paranoia, myoclonus, and so on. So I'm deliberately making this explicit because sometimes if we use midazolam, which is one of the most common medications we use for palliative sedation, if we use that for something else, such as myoclonus or delirium or some of these other symptoms, our intent in those situations is not to render the patient unconscious until they die, but rather just to control their symptoms to the point where they're comfortable. And so sometimes people see an order for midazolam and they immediately jump to the conclusion that, oh, Dr. Braun is using palliative sedation in this patient. So we as healthcare providers need to be very explicit about our intention when we order sedating medications such as midazolam and phenobarbital and other sedating medications. Often when we talk about palliative sedation, we talk about the principle of double effect. And a brief definition is as follows. The principle of double effect says that the action must not be immoral in itself. So the action in palliative sedation is giving medications to relieve discomfort. That's not immoral. That's morally and ethically an imperative. The good effect must be the intended effect. So in the case of palliative sedation, the intent is that we're going to relieve suffering. The intent is not that we hasten death. That's the secondary or double effect. The bad effect, death in this case, or the risk of death, must not be necessary in order to achieve the good effect. In other words, we're giving palliative sedation with the understanding that we may have to render them unconscious, but they will inevitably be comfortable in that state without having to bring about death itself. And then finally, the reason for the action must be compelling enough to place the person at risk of the bad effect. In other words, we, in this case, have said, this is an intractable symptom. We cannot bring about acceptable comfort in any other way. Well, is this legal? The U.S. Supreme Court has clearly said that assisted suicide is illegal, but they've affirmed the acceptability of the double effect. In Canada, to my knowledge, we don't have that legal precedent, at least not a clear one. And the question is the principle of double effect enough to justify the use of palliative sedation, ethically and legally? Actually, in Canada, the Senate helped us out a little bit. The Senate report that was released in the last decade said that one of the things we needed to do to improve the care of dying was to develop guidelines for the use of palliative sedation. So that's what we did where I practice. We also decided we would look at some of the quality of care issues when it comes to palliative sedation. And when we put our heads together as an interdisciplinary team of people working in Calgary, we came up with questions like, what constitutes refractory or intractable symptoms? That is, symptoms that cannot be adequately controlled despite aggressive efforts to identify a tolerable therapy. It's not as easy as just saying it. We talked about how there were variations in the use of this care when physicians with differing skill levels initiated palliative sedation. So some people found that a symptom was intractable much sooner than others. They were willing to try or were aware of other interventions that might help. And we also thought that given the controversial nature of palliative sedation, we needed to be very careful about documenting the consent and the decision-making process that went on for using palliative sedation. Well, here very quickly is are the criteria that we use for developing this guideline. Number one, the patient had to have a terminal illness. The patient was suffering from at least one refractory symptom. Death was considered to be imminent, and we said within days, recognizing that that can be difficult to ascertain, and that a DNR must be in effect. This is not in your handout. This is a simple algorithm to define what in fact is an intractable symptom. And it really asks, first of all, are further interventions capable of providing relief? And if so, is it anticipated that there would be morbidity of that intervention that would be tolerable to the patient? And if so, is it likely that we could bring about relief within a reasonable amount of time? If the answer to all of those questions is yes, it's probably a difficult symptom and not an intractable symptom, and we should look at other therapies. We also said in our guideline there should be a process. Once we find a patient that fits all of those criteria, we recommended that an attending physician seek a consultation with someone with expertise in pain and symptom management. We said that there needed to be careful discussion with the patient, if appropriate, if they were able to participate, their family or their decision-making agent, and the palliative expert then arranges for sedation and monitoring, and that we needed to very carefully document that criteria and the decision-making process. We then did a study to see whether this guideline would improve care. We wanted to assess the use of sedation of intractable symptoms in the Calgary region, and we wanted to assess the use of our guideline to see whether we actually improved care. We looked at the charts of those patients who died in one hospice, 3 hospitals, and in our home care program over 2 4-month periods, 4 months before and 4 months after implementing the guideline. And we found a total in both groups of 91 patients who definitely received palliative sedation, so about 5% of our patients. We looked in our audit to see whether in fact there was documentation that our patients were close to death, that a DNR was in effect, that there was documentation about consent and decision making, that there was in fact an intractable symptom, and that someone with expertise in pain and symptom management had participated in the care and the decision making around that. And here's what we found. In fact, we found that, this is a little bit confusing, the numbers on the bars are actually absolute numbers, not percentages. But there was actually one patient in which the reviewers of the chart said this patient was clearly not close to death, and they were palliative sedated. And we found that there was a group of patients in both pre and post audit that it certainly was not clear from the chart that they were close to death. So this suggested that we were using palliative sedation in some instances when death was not imminent, or it certainly was not adequately documented that it was so, given the patient's condition and so on as documented on the chart. So that was a bit of a concern. Then we looked at whether or not there was clear documentation about consent. We in health generally think there should be consent when we do an appendectomy, consent when we do other diagnostic procedures. We thought there should be at least some documentation in the chart stating discussed with patient, discussed with family, etc. And we found that in only 20% in the pre-implementation phase and 34% of patients subsequently was there documentation that at least some discussion had taken place. Now I suspect discussion took place in many more, much higher proportion of those cases, but the documentation was clearly lacking. The next thing we looked at was the proportion of cancer patients that were sedated by site. And there's something funny about the percentage of cancer patients on the axis on the left. So just ignore the numbers. The proportion, the heights of the bars are correct, but the numbers are clearly not right. The numbers that were sedated was lower than 25% in hospice. But what we found, the key message from this slide is that the proportion of patients sedated at different sites varied tremendously, and we couldn't explain that. Patients at hospice were not much sicker, and we wouldn't have anticipated that they would need sedation much more frequently than patients at the hospitals, for example. So again, demonstrating a wide variability in the use of palliative sedation. The next thing we looked at were the symptoms for which people received sedation. And we found that delirium was by far the most common. The next set of bars, which is not labeled, was restlessness. So probably a lot of those patients were in fact delirious. After pain came shortness of breath or dyspnea. So again, a wide variety of symptoms that prompted people to use sedation, but clearly delirium was the highest. We looked at symptoms for which, or situations in which there were clear justification for the use of palliative sedation, and we found that a significant portion, probably over half, we couldn't find evidence in the chart that their symptoms were in fact intractable, that there were other things that could easily have been entertained. And when we looked at those cases, we found that most of the time, the vast majority of the time, the patients were clearly delirious, as documented in our chart, or agitation was prompting sedation. And although there wasn't enough documentation in the chart, we think that most of those patients were delirious as well. So here's an example of where delirium probably not managed appropriately, and in some cases, sedation being used to manage it, perhaps not always appropriately. Our conclusions then that were in many cases, sedation is administered without following guidelines, as outlined in our clinical practice guideline, and that this appeared to be a systemic problem. It wasn't one physician or one location of practice. We found that sedation for intractable symptoms appears to be used to a variable degree, really depending upon the location in which the patient was cared for, and that delirium appears to be a very frequent symptom for which delirium is used, and that under-recognition and or mismanagement may in fact lead to the frequent use of sedation, and really reinforcing the first part of our talk this morning about the need to be very conscientious about recognizing and treating delirium.